All right. Welcome, everyone. Thank you so much for joining us this World Lichen Sclerosus Awareness Day 2025. Can you guys believe this is going to be, I believe this is our third or fourth year that we are doing this. And we are so happy to have Dr. Jill Krapf back with us. If you do not know who she is, you need to jump on it. She is an educator, a researcher, a lichen sclerosis specialist, and author. She is so many things, and we are so blessed to be able to learn from her today. And so, just a few housekeeping things. Please keep yourself muted. Please use the chat to talk to each other, ask questions. As we go through the presentation, I will be grabbing your questions, and after the presentation, we will have a Q&A portion, and we will get through as many questions as we can. And then, yeah, we're just going to have some fun and learn about LS. And we do have closed captioning available. So in the menu, either at the bottom of your screen, or if you're on a mobile device, you may need to tap your screen. You are able to turn on that closed caption if you so need it. The recording will be available on our YouTube page after. Give me about 30 minutes to upload it there. And without further ado, I'm going to let Dr. Krapf take it away. Welcome.
Excellent. Hello, everybody. I'm just going to pull up my presentation. All right. Give me a thumbs up if you can see it. Excellent. Excellent. All right. So my name is Jill Krapf. I am a board certified OBGYN, no longer delivering babies anymore. So gynecologist, and I specialize in vulvar pain conditions and skin conditions like lichen sclerosus, which is one of my areas of research and passion and clinical areas as well. And so we're going to do a bit of an overview presentation on lichen sclerosus today, just hitting all the high points, the main topics, including some more recent research that you may or may not have heard about. And then I really want this to be a jumping off point for a full discussion. So my presentation part will be about 30-40 minutes, and then we'll leave the rest of the time for me to answer questions. Please remember that I am a doctor, but I may or may not be your doctor, and so I cannot answer individual medical questions, but we can talk in theoreticals, we can talk in broad senses. If you do want your individual medical questions answered, please schedule an appointment. I'm happy to do that on a one-to-one basis. All right. Okay. Here are my disclosures and disclaimers. I am on the advisory board for Lichen Sclerosus Support Network, and that is a volunteer position. And this is an educational session. It should never be considered medical advice. I am not your doctor. I'm not giving you medical advice. If you need individual medical advice, please see a practitioner familiar with your condition. There is a directory on Lichen Sclerosus Support Network, so you can find a provider, hopefully in your area. And as education improves and awareness improves, we're going to have more and more providers, hopefully in your neck of the woods. So that's our big hope, and to have training for them. So that's a big initiative that we are doing this year. And then any patient cases that we discuss or that I discuss are hypothetical. They're based on usually a combination of patients and their presentation. So if it seems similar to you, it's not you, not an individual patient. All right, so our learning objectives for this session: to identify the sexual health consequences of vulvar lichen sclerosus in people of all ages, right? Lichen sclerosus can happen in all ages. Lichen sclerosus can happen in men as well as women. We're going to be focusing on vulvas and vaginas today. The second learning objective is empower. Empower yourself to discuss sexual health with your healthcare provider, to discuss lichen sclerosus, to really get this out there so it's not an area of shame or an area of silence. We need to be out there about this, because if we can't talk to our partners and our providers, then who are we going to talk to? And just the fact that everybody is out here today and this is a safe space and we're able to talk about this together, it makes me so happy. So thank you for even being brave enough to join today. I think that's really powerful. We're also going to, and this is blocking, implement a vulvar healthcare plan that promotes sexual health, right? Talk about why sexual health is important when talking about lichen sclerosus. We're going to cover all of the medical things, but sexual health is health is medicine, and so that is important as well. All right. Let's see. Okay, so what is lichen sclerosus? Lichen sclerosus is an inflammatory skin condition that predominantly affects the anogenital area. So we know that it can affect the vulva, but it also affects around the anal area. And we can't forget that part, because I have a lot of patients that come in and they may have no vulvar symptoms. Maybe everything, all of their symptoms are located around the anal area, and that's still valid as well. It's autoimmune in origin with a genetic component. So we know, based on studies, and there's more studies that are certainly needed, but there's about a 12% chance or risk of having a mother, sister, or daughter with lichen sclerosus if you yourself have lichen sclerosus, right? And so we know that there is a genetic component. We have identified some of the genes that may be involved. I was actually a part of that research, but it's not clear cut. We don't completely understand it. And I would say a majority of people with lichen sclerosus do not have a familial connection. It affects people of all ages, but is most often diagnosed around and after menopause. And we have a few theories about this, but we know that lichen sclerosus can affect children as well. We also know that when estrogen levels are low, such as in kids before puberty, as well as in perimenopause and menopause, that itching tends to be more common, not only in the setting of lichen sclerosus, but like literally everywhere. Like people have itchy ears, and itching tends to be a little bit more of a symptom when estrogen levels are low. And so if you look in the textbooks, and hopefully this is changing, but we used to call this diagnosis a bimodal diagnosis, or have a bimodal distribution, meaning it's detected or diagnosed in kids before puberty and in postmenopausal women. And we now know that lichen sclerosus affects people of all ages. And some of these studies that are coming out now, including a big study that I led, is showing that the symptoms may be different in people who are of reproductive age or premenopausal women. Inflammation in the skin leads to skin thickening as well as scarring. So lichen, so I'm a big science nerd. I can't help it. And I love word origins. I mean, you're going to get this whole thing from me. I'm sorry. But lichen in Latin means thickening, like a tree bark, right? Sclerosis means scarring. And so there's two components of this condition. There's the inflammation component that causes skin changes, and we're going to go into great detail about that. But a part of the skin change can be thickening in the middle layer of skin. Thick skin tends to be itchy, like psoriasis or eczema. So that's where the itch symptom comes from, is the lichen component. And then there's the sclerosis component, which is where there's fusion and resorption and things that stick together that shouldn't stick together, and covering different components like the clitoris. And so there's that scarring component as well. And when we're talking about treatment of lichen sclerosus, we have to be cognizant that of what something treats and what it doesn't treat. So we'll go into a lot of detail about the common treatments that exist and what their limitations are, what they treat and what they actually don't treat. Lichen sclerosus is not curable. There's no cure for lichen sclerosus, but it is manageable, and it's absolutely manageable, just like menopause, just like genitourinary syndrome of menopause, or GSM, which is basically menopause or lack of estrogen testosterone that affects the vulva, vagina. We used to call that vaginal atrophy, and so that's the updated term for it, is GSM. Menopause is not curable, right? It's manageable. And same with lichen sclerosis, not curable, but manageable. Same with autoimmune thyroid diseases and other things that are autoimmune in this way. What are the symptoms of lichen sclerosis? Well, all of you know the symptoms of lichen sclerosis, of course, but what I want to point out is that not everyone has the same symptoms. Some people have more of the lichen symptoms. Some people have more of the sclerosis symptoms. Some people are lucky and they have all of the symptoms. You know, it can present very different in different people, which, as a practitioner who specializes in this, for me, I love that challenge of addressing people where they are, finding out what their symptoms are so we can target their symptoms. But for you, it can be very frustrating, because everyone does present a little bit differently. But in general, we like to divide the symptoms into two different buckets. All of this is how we think about things, right? So the lichen symptoms, which are the thickening symptoms, are going to be what is addressed typically by a topical corticosteroid, right? If you use that in your treatment regimen, or a calcineurin inhibitor, immunomodulator like Protopic, tacrolimus, or pimecrolimus. Those are going to address all the thickening symptoms. So these symptoms are things like itching. Oh, I have the layman's term, like what we call it in real life. And then in parentheses, I have the medical term, or what we write in our note, or we call it among doctors. So itching, we call that pruritus. Irritation, that's both. White patches, hypopigmentation, lichenification, that's a mouthful. Paper cuts, cracks, we call those fissures. Bruising, purpura. And then there's the scarring symptoms, like coverage of the clitoris, which we call clitoral phimosis. Narrowing of the vaginal opening, introital stenosis. Pain with intercourse, pain with insertion of any type, dyspareunia. And tearing, which we call vulvar granuloma fissuratum, or VGF. How common is this? The bottom line is we don't really know. Unfortunately, there's a lot of misdiagnosis. There's a ton of underdiagnosis. It's probably more common than we think. Kathy and I were just talking about how it is no longer classified as a rare disease, although it is still recognized in the Registry of Rare Diseases, or NORD. Research estimates 1 in 300 to 1 in 1,000. I think it's on the lower end of that, or higher end of that, right? Um, there was a gynecology practice that looked at this, but they were specializing in vulvar conditions, and they said 1 in 70. Maybe that is an overestimate. We're not sure. It's more common than we think, and it's often missed or misdiagnosed. I don't believe it to be rare. What is lichen sclerosis an autoimmune condition? We get this a lot. If you would have asked me this about 10, 15 years ago, I would say that we don't know. But I can say now that we actually do know, because we've done a lot of the bench research and a lot of the genomics that have revealed that indeed lichen sclerosis is an autoimmune condition. Now, remember, when we talk about an autoimmune condition, it basically means that the local immune system within the skin is misfiring, right? It's basically overzealous or reacting to things like our tissue that it shouldn't really react to. Now, with the immune system, whether it be our skin immune system that's kind of keeping the bad stuff out and the good stuff in, or whether we're talking about our whole body immune system, right? There are many things that affect how our immune system works, right? Hormones, diet, exposure, stress, all of these things, even things that we probably haven't even identified yet in our environment, affect the function of our immune system, other conditions that may be occurring in our body. And so I think that there's a lot more research to be done. Right here, you're going to see some work that I was involved with at George Washington University, looking at the autoimmune pathways. What was really important about this study, so basically what we did is we took biopsy specimens from willing participants, so wonderful people who donated, their time and allowed us to do biopsy specimens. And this was in there was a genetic part of the study as well. So we were looking at mother-daughter, sister, familial, dyads or more, and doing biopsies from the lichen sclerosus area on the vulva, as well as a biopsy from the upper thigh of, normal tissue or non-lichen sclerosus tissue. And that was all processed and evaluated with a wonderful group of bench researchers that actually specialize in cancer surgery, cancer research at GW. Unfortunately, the lab has since closed down with COVID and everything. But what we did find is we found what the pathway is with lichen sclerosus, and we found some targets that allowed us to really explore some more targeted therapies that are non-steroid therapies for lichen sclerosus, which we're continuing to explore, like Jax inhibitors. And that's where this came out of. What is my doctor looking for with lichen sclerosus? So basically, it goes back to what we were talking about before with lichen, the thickening component, and sclerosis, the scarring component. When we talk about symptoms, those are the things that you feel. When we talk about signs, those are the things that your practitioner, your clinician sees, or what you see, right? And so we're talking about the hypopigmentation, that white appearance, the lack of skin pigment. Now, before I go any further, let me just break this down because I think that it's really important to not know these things, obviously, but also know the why behind all of this, right? Like, why is the skin white with lichen sclerosus? Why is there fusion? Why is there clitoral phimosis? Why does this happen? Why is there itch? Why does this stuff happen, right? And so the idea here is, if you've ever heard, there's 7 layers of skin, right? The bottom layer is called the basement membrane. I envision it like an apartment building with 7 floors and the basement on the bottom. I'm in Florida now. We don't have basements, but I came from the north and we did up there. So the basement, in the basement, there's a protein that the body identifies as not self. That's the autoimmune component of this. And that protein, the presence of that protein brings in inflammatory factors from the local skin immune system to fight the protein. And that inflammation in the basement, it looks like little purple cotton balls on your biopsy specimen. But it's like smoke in the basement. It changes the way that the skin cells regenerate in the layers of skin above. And so it's responsible for the skin changes that lead to what we see in a biopsy specimen, which your pathologist looks at. And then it leads to the signs that your clinician sees, and that leads to the symptoms that we feel. So the inflammation basically attacks the pigment in our skin. Those are called melanocytes, like melanin, and it attacks those. And so the skin appears white because it's lacking pigment, right? The inflammation also changes the way that the skin cells regenerate in these layers. And so the middle layer can actually incorporate stiffer forms of collagen, right? And not only does it incorporate stiffer forms of collagen, but it incorporates it in a more haphazard distribution. And that leads to a thickening of the middle layer of skin. Now, Between the middle and the top layer of skin, there's almost like half of a zipper, almost like the top of a castle. Those are called reedy ridges, right? And so that's what interlocks the top part of the skin to the middle part of the skin. You have a blunting or a loss of the zipper-like quality of those reedy ridges, which can cause shearing. It can cause bruising if blood kind of gets trapped in there. So it can cause the fragility, right, of the skin that we feel, or the sloughing even. And then the very top layer of skin at the very top actually thins out. So we used to call lichen sclerosus et atrophicus. And the reason that we used to call it that is because there was a thinning component at the very top. But the problem is that got really confusing when we talk about topical steroids. So we'll clarify that later in the presentation. But that's basically what's happening. And that's why there can be micro tears and fragility of the top layer of the skin. So with that background, let's just take a deep dive right into this. So hypopigmentation, right? White appearance of the skin, lack of skin pigment because of the inflammation. And when that happens, that doesn't typically reverse. There have been some promising results with some Jax inhibitors because they're used to treat vitiligo. Vitiligo is whitening of the skin or loss of pigment without all the inflammation. So you don't have all the scarring and itching and everything. You just have the whiteness. And so there are some medications that are targeted that are showing promise in this, which is really exciting. Lichenification, that thickening appearance of the skin, the wax paper crinkling, that's that middle layer at play. If the middle layer is thickened, then we can see a texture change on the top of the skin. And that is what classifies lichen sclerosus as what we call active, right? I don't have x-ray eyes, I wish I did. I can't see how much inflammation is in the basement. I can't see how thick that middle layer is unless I do a biopsy. But what I can see is the skin texture changes on the top. It's kind of like if I had a bucket of muddy river water and I swirled my hand underneath, you wouldn't see my hand churning, but you would see the ripples on the surface, right? That's what I'm looking for. Fissures, paper cuts, cracks, that can either be due to that layer being thick and it can crack like concrete, right? Or the top layer can be really thin and it can split almost, and that we call those fissures as well. It just depends how deep they are. Purpura is bruising or blood under the skin surface. Remember how I talked about the loss of those zipper-like quality, reedy ridges, and then with skin, trauma, those little capillaries can break open and you can get little bruises under the surface. And then what we always worry about, right? Whenever there's inflammation present, then skin cells are more likely to make mistakes. And mistakes are basically precancer or unfortunately squamous cell carcinoma. There's a 5% risk of squamous cell carcinoma in the setting of lichen sclerosus. Studies and meta-analyses have shown that this is an active lichen sclerosus. Typically, if lichen sclerosus is being treated or suppressed, and we'll talk about how to do that, the risk goes down to baseline population risk, and there's not an increased risk in a treated or a suppressed or in remission population, right? And so precancer we call VIN, vulvar intraepithelial neoplasia, VIN, which is precancer, and then cancer. And when we're looking for cancer, obviously you want to go to a clinician, a doctor, someone who's familiar with this, but we're looking for non-healing areas. So if there's any clumped areas that are just not responding, not healing, anything that bleeds easily, oh, that puts up my red flags. So that's something that I would want to take a look at and want ultimately biopsy. All right, and then there's the scarring component, the clitoral adhesions. Adhesions means skin sticking to skin, so scar tissue sticking to the clitoral hood, to the glans clitoris. There can be things that get trapped behind there. It's like having a grain of sand in your eyeball. It hurts, it's uncomfortable. Clitoral phimosis, inability to pull back the clitoral hood off the glans clitoris. I think it's so important that we even examine clitorises, right? I mean, as doctors and as women, right? I can't even tell you how many times I have seen patients that have complete clitoral coverage, complete phimosis, and they said, doctors never even made a comment about that you can't see my clitoris, right? Like I thought I had a 19-year-old who had lichen sclerosus likely as a kid, right? She saw me as an adult, as a 19-year-old, but she had complete coverage. And she said, I didn't think I had a clitoris. I just didn't think I was born with one, right? Luckily, she was having pain, and I was able to uncover that clitoris with a minor procedure, her clitoris with a minor procedure. And now she has wonderful orgasms and no pain, and she has a clitoris that you can see, and she's very happy. But just the fact that, we don't always, we're not always familiar with our anatomy, right? The problem is we don't look until there's something wrong, which is human nature. But I'm hoping with, teaching the next generation. I have a 6-year-old myself. We always go over what we call our parts, what are the labia, what's the vulva, what's the vagina. And I think that, that's a good thing, right? We have to be able to communicate these things for safety reasons as well as for communication reasons. All right. Introidal stenosis, basically narrowing of the vaginal opening due to scar tissue at the top and the bottom of the opening. People can even have tearing or splitting in the area of scar tissue. How is LS diagnosed? LS is typically diagnosed clinically. You can also do a biopsy. Some people believe you always have to do a biopsy. Some people believe you never have to do a biopsy. My general rule of thumb is if the biopsy is going to serve a purpose for us, I would recommend a biopsy. Now that purpose can be different. It can be anywhere from, okay, I think this is lichen sclerosus, but I'm not sure, right? Then you need to do a biopsy. This is lichen sclerosus, I know that, but I'm worried about a precancer. Yeah, you need to do a biopsy. This is lichen sclerosus, but there may be an overlying condition like a vulvar yeast, or like a baby diaper rash situation, or lichen simplex chronicus, an itch scratch itch cycle, or a combination of lichen planus and lichen sclerosus. Then yes, these are all reasons to clarify further with doing a biopsy. I have patients come from out of the country and they need a biopsy report. It's their ticket to get care, right? Then we'll do a biopsy, whatever they need, right, to get care. What are we looking for in a vulvar skin biopsy? We already went over this, so I'm gonna go through this a little bit faster, but this is what we were talking about before. So A is that top layer, that hyperkeratosis of the epidermis, that top layer of skin. That's kind of like that slough layer or that like fragile layer, right? B is that top layer of thinned out skin. It lacks those reedy ridges. That's going to be between the purple and the pink underneath that hold it together. So we call that epidermal atrophy with loss of reedy ridges. So I put like the layman's term, and then I put like how pathologists talk. C is that collagen, the very uniform, stiffer forms of collagen under the top layer. We call that homogenization. Oh, that was a mouthful. Of the collagen below the dermal epidermal junction. And then down at the bottom, see all those little purple dots, right? That is the smoke in the basement. Those are the inflammatory white blood cells. So that's the T cell infiltrate. Inflammatory cells collect at the bottom layer, lichenoid T cell infiltrate near the basement membrane, right? All right. Can lichen sclerosus lead to vulvar cancer? Yes, lichen sclerosus can lead to vulvar cancer, but also lichen sclerosus that is well controlled and in remission has a very low risk of vulvar cancer. So the risk of vulvar cancer is about 4 to 6%. I usually tell patients 5%. It's just an easier number to remember. We do worry about precancer, VIN, especially differentiated VIN. This has a higher likelihood of leading to squamous cell carcinoma. I think the bottom line here is that adequate treatment with something that suppresses the inflammation, such as a topical corticosteroid, it's been shown in studies, and these are robust studies. These are not small trials. These are not pilot trials. These are big, robust studies with few hundred people. Usually, there was a really big one done in Australia, and meta-analysis, which is where we take multiple studies together and all of the data from the individual studies, and then we combine it all together and analyze it all together to give it higher power. And we know that topical corticosteroids decrease risk of vulvar cancer and lichen sclerosis. Okay, this is what the studies show. They're cited below too. How is lichen sclerosus treated? Well, I mean, a lot of different things affect the immune system, right? And so I like to take a holistic approach to treating lichen sclerosus. There are medical options. I have medical and energy-based modalities here, and then hopefully my next slide has more of a holistic approach. But if not, my Instagram has it. So ultra potent topical corticosteroids are our gold standard of treatment. That's what's supported by the two major guidelines on lichen sclerosus. There's a lot of evidence behind it. It's not just we decided that. It's like there's a ton of evidence. Second line are calcineurin inhibitors, like tacrolimus or pimecrolimus. Another option is platelet-rich plasma injections. However, there's very limited evidence for that it decreases inflammation. So we have to be careful with what a treatment may do versus what it may not do. That is still considered experimental. Energy-based modalities, photodynamic therapy, high intensity focused ultrasound or HIFU, as well as fractional CO2 laser therapy like your Mona Lisa or your different types of lasers. All of those are still considered experimental therapies. There have been studies and there are more coming. There's actually a huge trial that's going on right now looking at laser versus topical steroids, which is what we need to make good decisions about all of this. But right now, what we know is that that laser and energy-based modalities, they can help with the symptoms, like what you feel with lichen sclerosus, because they likely, with laser, it causes microperforations, which basically stimulate collagen formation. So it can change, the tissue a bit to make the tissue a bit healthier. There may also be with some of these modalities, such as HIFU and photodynamic therapy, like bringing in blood flow, right, to help with the tissue. But none of these modalities have been shown to decrease inflammation. There was a randomized control trial that actually I was involved with Dr. Andrew Goldstein and a number of our colleagues, and we did biopsy before and after a full series of laser treatments, and patients felt better. They looked better. Their doctor, who was grading all of this, said, yes, they look better, but the biopsy did not show decreased inflammation at the end of the treatment compared to before the treatment. And all of this was blinded, meaning the pathologist looking at it didn't know who had laser treatment versus who had sham treatment. And the patients were blinded as well. They all had either sham laser or real laser, and they didn't know which one they were getting, and the doctors didn't know what they were administering. So it's like the best type of study that you can do. But even then, these treatments are, like I said, experimental, and I like to consider them as what we call adjunct treatments. Like they can be added, right, if needed. But remember, something that decreases inflammation, whether that be lifestyle for our immune system, whether that be topical corticosteroids, which are first line and gold standard, or whether that be a second line treatment like calcineurin inhibitors, or whether that be one of our newer topicals like a Jax inhibitor. All of those target the autoimmune response, and that is what we need to ensure that we're not progressing into a cancer realm. Okay. Are there any non-steroidal treatments for LS? I think we kind of talked about all of this, but I think the biggest thing is that there are some new medications that are coming out, such as Jax inhibitors, it's really exciting. And we were studying them for lichen planus, then we studied them for lichen sclerosus. And so some of that should be coming out soon. The main issue right now is with insurance coverage. These medications are insanely pricey. And so I think that we will get there in the next, I don't know, maybe 5 years, but we're just not quite there yet. And then energy-based therapies may be a helpful adjunct or helper, but we're not there yet with they're not first line. They're all considered experimental right now. Okay, oh good, I did. How can I holistically improve my LS symptoms and flares? So promoting local immune function, a healthy diet, stress management, limiting irritant exposure, protecting the skin barrier. I have one to add. And that is oftentimes if somebody is either in menopause, perimenopause, lactating, breastfeeding, they are not ovulating, they have PCOS, if they have any sort of hormonal component, it's also important to optimize the tissue in that area hormonally as well, because here's the deal. A topical steroid, there's only one job that a steroid does. Steroid does one job, that's decrease inflammation. And that's whether steroids come in many forms. They're used for many conditions, right? So, like if someone has asthma and they do an inhaled steroid, right? It decreases inflammation in the lungs. If someone has, something else going on, they take a steroid, you can take a steroid by mouth with a dose pack. You can take a steroid, inject a steroid. We want to do the most local thing, which for lichen sclerosus is topical, right? But a steroid only does one thing. It only decreases inflammation. It's not going to bring back the hormones in the tissue. It's not going to bring back blood flow into that tissue. It's not going to do these skin regenerative things. So it's only responsible for just that. And then once we decrease inflammation, the skin needs to regenerate in a healthy way. If there's other conditions present that are preventing that, like menopause, then we're only going to get so far, and there's still going to be symptoms related to those other conditions. So I think that that's a really important component to remember. All right. This is another really important component to think about. Lichen sclerosus can be in remission and still be symptomatic, right? So when we talk about active versus remission, we're really talking, it's like what we're talking about is there a cancer potential, or is that cancer potential greatly reduced, right? So when someone is active, it means that they have active lichenification, they have thickening, they have a texture change of the skin, they have patches, right? The white patches, right? Now, that means that there's high levels of inflammation under the surface. And if there's high levels of inflammation, it means they're at higher risk for development of precancer or cancer, okay, from a medical standpoint. Now, when someone's in remission, that means that the skin texture is normalized, it's healthy. Now, someone in remission, remember, if it's with a topical steroid and they get in remission, it's not going to reverse the color changes. It's not going to bring back pigment to the skin. It's not going to unstick the tissue that is stuck together. It's not going to unfuse someone's clitoris. It's not going to, it's not going to do those things. It's only going to obviously decrease inflammation, normalize skin texture, that wax paper texture, and it's going to decrease our cancer risk. So you can still be symptomatic because there's a hormonal component. You could still be symptomatic because there's an overgrowth of yeast on the surface. You could still be symptomatic because there's a bacterial component. You could still be symptomatic because you have scar tissue, right? Residual scar tissue, coverage of the clitoris, something stuck behind there, or pulling or tightening or pain or tearing with intercourse or vaginal insertion. So there's a lot of reasons you can still be symptomatic even if inflammation is not active. How does LS affect sexual function? Women with LS are less likely to have vaginal intercourse. We know this. They're less likely to have oral sex, to masturbate, to have, to display these behaviors. Dyspareunia is frequently the initial presenting complaint of women with lichen sclerosus, right? Especially in our 20, 30, and 40-year-olds. Despite adequate medical treatment, women with lichen sclerosus continue to have significant sexual dysfunction, as assessed by the main rating scale for sexual dysfunction, which is the FSDS. And that's because if they're being treated, it's only treating the inflammation, right? Clitoral phimosis can cause anorgasmia, can cause lack of orgasm, blunted orgasm, delay of orgasm, all of these things that affect sexual function. So these are all things that we know, and these are things that are very important, and all of this is cited below. What sexual symptoms do women with lichen sclerosus experience? Well, we did a study on it to figure that out. And this figure is from one of my studies that I've done with a number of wonderful colleagues who have contributed greatly. But you can see this was an internet-based survey, which has its pros and has its cons, right? The pro is that people can answer anonymously, so we get more of a, full answer, real answer. The cons are, we couldn't you don't have the safeguards in place of, diagnosis and things like that. However, we did limit this to people that have biopsy confirmed lichen sclerosus. We also opened it up to people that were clinically diagnosed, and then we compared the numbers, and guess what? There wasn't a difference in the numbers. So, this is all comers here, but this was in the biopsy confirmed group. So you can see that we broke it off into symptoms that people experienced, symptoms that actually made you go to the doctor, that prompted medical evaluation, and then symptoms that actually like affected you the most. And when we talk about symptoms, I think it's really important to differentiate these things. This may sound like nuance, but it's important. Like, what did you have? What actually brought you in? And then what bothers you, right? And so you can see, I think the highlights with this is that decreased clitoral sensation was heavily is heavily experienced, right? We just don't tell our doctors about it, okay? And we don't go in for it, but we have it, right? You're experiencing it. And then dyspareunia, again, very much experienced. We do go to see our doctors about it, but at a much lower rate. And it affects people a lot, okay? Tearing with intercourse and insertion, again, we see the same pattern. Pruritus, interesting, different pattern. It's not as experienced, maybe, but it is in some people, and it's very, very bothersome when it is, but it's not experienced in everyone. But when we have it, guess what we do? We go to the doctor for that, more so than some of the more sexual side effects. So you can see this is pretty interesting. Same with pain. What are treatment options for clitoral pain due to scarred coverage of the clitoris? I'm just spending some time on this because no one ever talks about this, right? So it's important that we talk about it. Cleaning the area, gently pulling back the clitoral hood, ensuring there's no buildup around the clitoris, especially when there's adhesions. Those can be sticky, and dead skin cells slough all the time from all over us, right? When they mix with moisture, it can turn into something called smegma, which is kind of like a white, kind of cheesy, like ricotta kind of texture, and then that can get trapped in around the clitoris, and it can ball up and cause pain. Identifying, removing, so when that balls up into little nodules, we call those keratin pearls. The skin is keratin, the upper layer of skin is keratin. So keratin pearls. And so identifying that as a potential for clitoral discomfort is a big step in and of itself, because oftentimes, we don't recognize these things. If moderate to severe, you may need to see a specialist. There's procedures that we can do if it gets to that point and they make a big difference. All right, let's see. All right, what are treatment options for decreased clitoral sensation due to coverage of the clitoris, right? So increased pressure if there's coverage of the clitoris, add vibration for stimulation to promote blood flow, scar tissue massage to generally break up the scar tissue between the clitoral hood and the glans clitoris. And then, if first line steps or, conservative steps are not working, then we want to look at, different options that we have, which can include minor procedures. In addition, laser therapy has also been evaluated for this as well. There's not a ton published on it. People have experiences with it, but we just don't have a lot in the research on it. What are the treatment options for tearing at the vaginal opening? So when there's scar tissue that's narrowing the opening, right? Or even more worrisome, like if someone has difficulty urinating because there's scar tissue, or the urine sprays everywhere because there's scar tissue, right? So optimizing the tissue health to make it more pliable and healthier is the first step. So decreasing inflammation of lichen sclerosus, ideally with something that decreases inflammation and that treats manages lichen sclerosus. Increasing hydration to the skin with a vulvar moisturizer or an emollient. Adding a topical estrogen or even a combination, estrogen, testosterone, or DHEA. There's a lot of hormonal options that we have that are local. They're safe. There's limited absorption into the bloodstream. They're absolutely safe. They do not cause breast cancer or anything else. And then treat underlying tight superficial muscles. If the muscles are tight under the surface, then that could be contributing as well. And so that's where I shout out. I see one of my pelvic floor physical therapists in the audience. And so our physical therapy colleagues are phenomenal with scar tissue massage, with tissue massage, bringing back blood flow to the tissue, with the tight muscles, with how we hold ourselves, with how we move in the world, with all the other things that can be involved, like our masseter tightness and the way that we walk and our feet and everything. So it's all connected, and they're wonderful. Shout out to all the physical therapists. All right. Okay. When should I see a lichen sclerosus specialist? Well, you can see a lichen sclerosus specialist at any time if you're concerned about lichen sclerosus, right? The difference is that as a lichen sclerosus specialist, I see lichen sclerosus multiple times a day, every day. I mean, this is all I see. And so it's hard to compare someone with that level of experience with someone who sees lichen sclerosus once a month or a couple times a year or what have you, right? Now, there's an issue with accessibility, right? Lichen sclerosus specialists are not all over the place right now. Maybe in the future they will be, but right now they're not. The directory, I want to shout out for that, so you can find somebody that at least, is interested and passionate and wants to see patients with lichen sclerosus, because that's a start. Being dismissed never feels good. But with a lichen sclerosus specialist, you remember that's an upper level of care, and sometimes that's needed, but it can be accessed at any time that you feel that you may need it. If you do not feel well equipped to manage your lichen sclerosus, then it would be a good idea to see a specialist. If you need a more personalized approach, right? If you feel like there's other things going on that have not been identified, first line treatments are not working. You've tried the first line treatments, they're not working. If you're interested, and of course, if you're interested in any surgical options for scarring, I definitely recommend seeing someone that has a lot of experience with these types of procedures. How do you find a clinician familiar with lichen sclerosus? Well, you head on over to the Lichen Sclerosus Support Network, and they have all your bases covered. So there's education, there's awareness, there's directories, there's support, there's meetup groups. I mean, it's just fabulous that this resource is available and has become what it has become in the last, what has it been, 6 years, 5 years? All right. How can I help with lichen sclerosus research to increase awareness and treatment for the future? Well, you can, if there's a research study, we're conducting a research study right now in Tampa, in New York, as well as DC, looking at a non-hormonal, non-steroid silicone film forming topical agent called Strata, to help as an adjunct for lichen sclerosus, to supplement whatever treatment someone's already on. So if you're interested in that, on my Instagram, I have a lot of information about that. If you are interested in participating in a study like that, you can, I'll give you 2 email addresses. So if you're in the Tampa Bay area, or you're able to travel to Tampa, then you can email researchjkmd@gmail.com. If you're in the New York area or the DC area, or you're able to travel to those areas, then you can email my research coordinator, Sylvia, SYLVIA, at vulvadinia.com. And if you email one or the other, we know each other. We'll get you to whoever you need to be. And there's other research studies going on. Go to clinicalstudies.gov, right? And clinicalresearch.gov. And there's a whole list of studies. You can search by key terms like lichen sclerosus. Donate to promote research, right? This research is so underfunded, right? It's so underfunded. And so and it takes, honestly, to find treatment options, like it takes it takes funding to be able to conduct these large studies, right? To reimburse the participants that participate, to allow for the data collection, for the office time, for the statistical support, for the processing of everything. I mean, it just costs a lot of money. Share evidence-based information as you feel comfortable in your network, right? To your level of comfort. That could be, you're walking with a neighbor and you share, like, or a friend, right? Like, you never know who could be struggling with something. Or, it could be, something more bold, like sharing an Instagram post or something like that. And so, yeah, all of these things make a big difference. How can I find support for LS? Well, it's World Lichen Sclerosus Awareness Day, and get involved with Lichen Sclerosus Support Network, and share, any of your gifts, right? Whatever they may be. All right, so here's how you can find me. You can follow me on my social media. I am on Instagram. I do share to Facebook. I'm not as active on Facebook, but I will sometimes respond a bit, at Jill Krapf, MD. And then you can find me at the Center for Vulva Vaginal Disorders in Tampa, Florida. That's the address there. And if you're interested in an appointment, it's appointments@jillkrafmd.com. We're happy to help you. And then if you're looking for a specialist in your area, please, check out the directory. I can say for me, people ask me all the time, people travel from all over the place to see me. Actually, I'll share with you, just because my practice manager, she got this for me for Christmas and for the holidays, and so I want to share it with you. Because it's so special to me. So this is a map, and on it are these little push pins. I don't know if you can see them, but these are where all the patients who have visited me have been from all over the world. So that's really special to me, that she did that. So I look at that, and it's funny because some of the far off places, I know exactly who that pin corresponds to. So it's very special. All right, so with that, let me open this up to a discussion, and I'm happy to answer any lichen sclerosis questions that you may have.
Thank you so much. That was amazing. As always, we have a ton of questions. So I'm going to try to get through all of them. Um, okay, so first one. Um, People want to know more about the Jax inhibitors. What can you tell us? What's the update? And for those who don't know, that's like the ops. Well, you can give us.
Opsilura.
There you go.
There's a number of Jax inhibitors. Okay, so there's some things that I can share, and then unfortunately there's things that I can't yet share. And so I will say that the study that we were doing with Jax inhibitors has concluded. However, there was some issues with data analysis. And so that data will be published. I actually received an email yesterday confirming that the plan was to go forward with that. This was a study that was sponsored by the pharmaceutical company that created the Opsilura, the Jax inhibitor, right? And so we are a bit under the control of how they want to proceed, as far as data analysis, statistical support, and the support that's necessary to take it from the data to an actual journal publication, right? And so we're in the process of that, and we're fighting very, very hard. Dr. Andrew Goldstein, myself, and a number of others. So we're working for you. We're fighting for you, because we did do the study. It has been completed. I can't share results, unfortunately, until it's officially published. That's just the rules of the game. So that's where we are. Our hope was that if we could like fully go through with this, that there would be some sort of coverage option, because it's available. This medication's available. It just doesn't have an indication, like an FDA approved indication for this purpose. And because of that, likely insurances likely are not going to cover it for a purpose that's not indicated, right? I don't know how much more I can share beyond that. I'm a little concerned. I'll share this. I'm concerned that it's not going to have that indication, at least from that company. So there are other Jax inhibitors that are available, and we are actively looking to do research with other interested parties to see if we can push this forward. So I think that's where we are with it. I know that's frustrating, but I think there's a lot of promise with Jax inhibitors and with these more targeted medications that are topical. And so I'm hoping in the future we will have more viable options.
Next question is about the Strata MGT, which is the silicone treatment. I also want to say we are going to be releasing a podcast and video interview with Leah Mitchell talking about this product, this research. So look out for that. That should come out next week. So you'll have more, a lot more information on that. So you don't have to go too much in depth because we do have over 40 questions.
Okay. Yeah, there was a quick question I want to answer. Do Jax inhibitors replace steroids? Yes. So there's a more targeted approach to counteract the autoimmune inflammatory cycle within the skin. So they would be a more focused approach than a topical steroid, and they would replace it. It's not an adjunct. It's actually, it would actually be a maintenance treatment. So as far as Strata, on the other hand, is an adjunct, right? And so it's basically what we're looking at is people who are already on some sort of regimen for lichen sclerosis, but they're not getting full relief. They're still symptomatic. And symptoms can be, it can be like our characteristic symptoms like itching, discomfort, what have you. It can also be symptoms like scarring symptoms, or it could be like that area bothers me, like I'm just not comfortable with it. It's like taking up space in my brain. And so all of these things is what we're kind of looking at its role. We know that topical silicone has a lot of utility in wound healing as well as scar. Right. And we use it characteristically post-operatively for scar reduction and for, in burn victims and things like that. So there's reason to believe that it would be helpful in a scarring condition. And so that's the idea. It would not replace an inflammation medication, but I think it has promise. So we're going to see. When I did my live, I got a lot of questions like, well, do you recommend it? And I'm like, well, I don't know yet. We're studying it. That's why we're doing it. But yeah, we're currently enrolling that study. And we're enrolling participants. We've already started enrolling in DC, New York, and then we've already started enrolling here in Tampa. It's going really, really well. So if you're interested, please, it's 4 visits. And so if you want to have more information, just contact us or listen to the podcast. Leah will talk about all of that, but it's an exciting study, I think.
We'll be sending out an email on that as with more details with that as well.
Mhm.
Is it common to have people with LS show anti-nuclear antibodies in high markers in their blood work?
No. So it's not. Lichen sclerosus is a localized condition. It's a localized autoimmune condition. It's associated with other conditions that have that same locality. So like hair loss in a corn-like distribution, alopecia areata, right? Autoimmune thyroid conditions like Graves and Hashimoto's. These are all like very like localized conditions, right? And so we don't typically see an positive ANA like we would. Lichen sclerosus is not associated with whole body autoimmune conditions. It's not associated with lupus. It's not associated with multiple sclerosis.
Next is, would you recommend, or sorry, if someone is recommended to use triamcinolone and clobetasol at the same time. Is this normal?
So it depends, right? So topical steroids are a tool. Tools can be used in many different ways. Some ways are good, some ways are not so good, right? We always have to have a justification for what we're doing. There's nothing inherently like bad or good, about these medications. All medications have side effects, right? You can have a medication that works, but it also causes nausea, so if a medication is going to work, it's going to have some good things about it and some like bad things about it. And so what we try to do as clinicians is we try to optimize the good things and limit the bad things, whether that be with instructions on how to take a medication, just like when we say, oh, take with a little bit of food, right, to limit your stomach upset. Right, same idea here. And so clobetasol is an ultra potent topical steroid, and triamcinolone is a medium potency topical steroid. And so there may be reasons why you would use one level on one area of skin and another level on a different area of skin, right? And I often do that. And so it's not necessarily a bad thing. Now, does it make sense to like mix them together and put them on the same place? No, like that doesn't make sense. But you want to know the reason behind the regimen that you're doing. And if you're not sure, you should ask your doctor why.
Thank you. And that also includes if you're like on a topical calcineurin inhibitor and a steroid. So
Yeah,
yeah, because we've had that.
exactly. I mean, they're working, those two things are working in different ways. And so there's different reasons why people could be on those different medications. So.
And can you talk about the lower potency steroids and the advance into vulvar cancer? So we know we have like studies as far as like the ultra potent steroids, but if someone's using a lower potency steroid, should they be concerned and go up to an ultra potent?
So actually most of the studies do use clobetasol. That's why we always talk about clobetasol, but you'd be surprised that, a lot of the studies incorporate many different types of steroids at different levels and different, potency levels. So the meta-analysis that was done was really incorporating many different types of steroids. They didn't have the power to look at like the differences, right, between them. But the main thing here is remission. Okay, it's remission. If you are in remission as far as your skin texture goes, then the chance of it progressing to a cancer is low, as opposed to if the lichen sclerosus is suboptimally treated or not treated and it's active. If it's active, your cancer potential is, like we said, the studies quote about, 4 to 6%, right? So it's not about the the level of steroid you're using. That depends on your individual presentation and what your condition is manifesting, right? So we want to meet it where it is. It's more about the tissue response and if you're active or in remission.
Next question is, what's your approach for treating or monitoring patients with DVIN?
Yeah, that's a very complex. That would be a very complicated answer. So typically with DVIN, we do remove it. So I will work in conjunction with a cancer doctor, a GYN oncologist, typically in those cases. Although I have removed DVIN myself as well, but typically it's excision that's involved. But it depends. There's other options as well. So that would require like a full consultation to determine what option is best for somebody that has that.
And someone said you mentioned clobetasol helps mostly with the lichen symptoms. What if you mostly have sclerosis symptoms? What's the best way to manage this?
Yes. So we talked a little bit about that in the presentation, but generally we want to get the tissue as healthy as possible. So not only obviously decreasing the inflammation, which was addressed, but also making sure that the tissue is hormonally optimized locally to increase that, collagen. And then after that, we're talking about, so you have some more conservative measures such as soft tissue massage, scar tissue release. And then you have second line measures, which are going to be more of your procedural measures. So there's procedures. I actually did 4 procedures this morning of this. So you can do lysis of clitoral adhesions. You can do something called a dorsal clitoral slit procedure. And then with the intro, that's for the clitoris. And then for the introitus, you can do a modified Fenton's procedure. Basically, there's lots of procedures that can be done for the symptomatic scar tissue.
What, okay, wait. Will a twice-a-week maintenance protocol of clobetasol cause vulvar discomfort, feeling of rawness? Could clobetasol be too strong of a steroid?
Mm. Um, yes. So anything can be too strong for somebody if it's not the appropriate if it's not so in different clinical situations, you could always use either too much of something, not use it properly, or be on a potency level that is either inadequate or too high, right? And so the art of this is to figure out how to meet the inflammation where it is, and that's done with an evaluation. Like, so that is purely with history and physical exam. The art of medicine is to find a regimen that is going to maximize benefit and limit adverse or side effects, right? And so when I'm making decisions, I'm putting all of this together. I think sometimes I often see it depends if you have a propensity for yeast, right? If you have yeast overgrowth with perianal candidiasis or yeast around the anal area, or you have vulvar yeast, right? It's almost like a baby diaper rash. Your vaginal culture is going to come back negative, right? It's not in the vagina. You don't have a discharge or a yeast infection that we commonly think of, but you have that redness or even scaling or sloughing or discomfort or itching on the outside, right? So it's important to identify, remember, lichen sclerosus skin by nature has like one hit to it, right? It's, the skin can be a little more fragile than if you didn't have lichen sclerosus. And then on top of it, you're adding either immunomodulator or topical steroid or something that's decreasing inflammation, but that's also suppressing the local immune function to a certain extent. We try to limit that as much as possible, but the inherent risk of overgrowth of yeast or bacteria is a little bit elevated in that case. You're kind of weighing these things out, right? As at least I am when I'm creating a treatment plan for somebody. And it's absolutely possible. It's not even just possible to do that. It's like what I commonly see, like people get better and then they have a maintenance regimen where they are better long term, right? Like that's our goal. But I do sometimes find that, it's either we're not using the topical correctly, right? If you put a topical steroid on the surface of the skin, remember with LS skin that's active, that top layer is thinned out. Remember we saw with the biopsy and we talked it all through. So if you're just putting a topical steroid on the top, like icing on a cake, it's going to thin out the top layer that's already thin, and it's never going to absorb all the way down to the basement where the inflammation actually is. So it can actually be more harmful, right? So what we typically recommend is if you're active, then we have you soak to soften that skin to increase penetration, and then rub in that topical steroid all the way down. So, all the way in. So it's absorbed in the skin so it can get down to that basement. Now, once someone's in remission and they're no longer active, they don't have to soak to the same level. They can get away with a warm shower, but they still need to rub in the topical until it's well absorbed. We never want it to just sit on the top layer like icing on a cake. Now, that's different than something like a vulvar emollient, right? When we're talking about things like Aquaphor, Vaseline, Vulva Bomb, like, oh, I don't want to name names, but like when we're talking about these emollients, those are protective, right? They're locking in moisture. They're supposed to sit like icing on a cake, right? So these are totally different ways of thinking about things and ways of doing them. But you have to have kind of a method to the madness. You have to know like why you're using the tool you're using and how to use the tool properly.
Thank you. Can you talk about hyperpigmentation?
Yes. Oh my gosh, yes. So we often see what we call inflammatory hyperpigmentation. Hyper means above, pigment is the skin pigment. So we see darkening of the area. This typically happens. So what happens is if you have lichen sclerosus and the inflammation goes down, whether that be with a topical steroid, some sort of treatment, or just naturally based on those things we talked about that affect the immune system, so the skin's smart, right? When those inflammation levels go down, the skin recognizes that and basically spits out pigment that, the inflammation was like fighting the suppressing the pigment. It spits out more pigment, and that's what causes inflammatory hyperpigmentation. It's not dangerous at all. It's a subtle sign to me as an LS specialist that you have lichen sclerosus that has been treated. And so we often see that on resorbed labia minora. We can see it around the clitoris. We can see it at the bottom where the perineum is. But when we see that, I sometimes will get referrals from other doctors who are scared. And I never like that's fine. If you want a second opinion just to look, just to say, oh yeah, that's just inflammatory hyperpigmentation, that's fine. Great. It's better than the alternative. But yeah, some people are really scared because they think it's like melanoma or something like that. And obviously get it checked out if you're ever concerned. But yeah, that's really, really common in people with lichen sclerosus.
Thank you. Can you talk about estrogen and use and lichen sclerosis and like as far as like application, timing, as far as like with a steroid and all of that?
Yeah, so all of that's going to be individualized, right? It depends on basically GSM or genitourinary syndrome of menopause, that menopausal component for the vulva, the urethra, the vestibule, vagina, and bladder. It's going to be dependent upon your history and your physical exam, so your clinical picture, and that's going to tailor what hormone therapy locally is best for you. There's also a patient preference part of this as well, because we can deliver local vaginal vulvar estrogen in different ways. There's creams, there's tablets, there's suppositories, there's a ring, there's a DHEA. When I say DHEA, I'm not talking about like the supplement that you get from Amazon and you take by mouth. I'm not talking about that. I'm talking about progesterone. So vaginal DHEA, that's prepared in a vaginal suppository at a specific like dosage that has been studied, and it's FDA approved as it's called Intra Rosa is the brand name, and it's available for the indication of dyspareunia as well as vaginal atrophy or GSM. So that's what I'm talking about. But anyway, there's a lot of different options when it comes to restoring hormone to the vestibule, to the vulva, as well as to the vagina.
And can you talk about LS and morphia? Are they two
Those are
different
two different,
expressions?
yeah, they're different. They're two different conditions. If you're concerned about that, I would recommend seeing a specialist or a vulvar dermatologist.
Um, Other than clobetasol or following clobetasol estradiol regimen, is there anything else you could do to avoid phimosis of the clitoris, urethra, and anus?
Yeah. So I think like restoring blood flow to the tissue, so making sure that the muscles are not tight under the surface, just to maintain healthy tissue. You mentioned those two things, which are very important. The recommendations are obviously going to be individualized. The idea with a maintenance dose of a topical steroid to decrease inflammation, the idea with a topical hormone is to, basically make sure that scarring does not get worse and to increase the tissue quality and health so things become more stretchy and more pliable and more functional. So that sounds like, a great start and a great regimen. Vibrator therapy can be very helpful for blood flow. So there's different wands that have vibration function for people that have pelvic floor muscle issues, but also there's the good old vibrators, right? To increase, to stimulate clitoral, not only the clitoris, but like the tissue around to increase blood flow, increase health of the tissue. Vibrator is probably underrated. Like we as doctors probably should be prescribing vibrators. They can do a lot of good.
Thank you. And we have also link blogs on our site talking about this as well. Can you talk a little bit more about the interaction with other secondary infections like yeast infections, UTI, and BV?
Yeah. So I think I see this a lot. So oftentimes, and I don't blame, I can't blame anyone if they're applying the steroid incorrectly. It's not your fault. You were never given instructions, or you may have been given wrong instructions. I mean, most likely you were just given a prescription and never told how to use it, honestly. And so I find that a lot of people are using steroids in suboptimal ways, that's leading to issues with overgrowth. Remember, yeast and bacteria live in and on us, right? They always live in low levels on our skin, in the vagina. It comes from the rectum, it's in the GI tract. I mean, it's just in and on us. So typically when we have a system that's functioning optimally, we're able to have like those the guards at the gate, right? And we're able to ward off overgrowth of these things. But when things are not optimal, then we can see infiltration of yeast or bacteria, but in the case we're talking about yeast, in the tissue, and then that can lead to symptoms. And that can lead to basically I call it like a baby diaper rash, just because I think it's important to distinguish it from the vaginal yeast infection that we think about in our 20s when you take antibiotics and you get the cottage cheese discharge, the itching, you know something's wrong. You use some over-the-counter medication or you get something from your doctor and it goes away. This is different. What we're talking about is more like in the tissue, around the anal area, up the skin folds, around the vulva, and all the nooks and crannies, it's more like a baby diaper rash. And so if that's present, obviously that needs to be treated in conjunction with maintaining and treating the lichen sclerosus and addressing any hormonal issues that may be at play.
Thank you. It says ibuprofen has been helping me with pain. Does it have any helpful effects on the lichen?
Not that we know of.
What about ulcers? Didn't see them on your list. So ulcers as far
Ulcers.
as there's a symptom or sign.
Mm. Ulceration. So yeah, so ulcer's tough. You can see ulceration and lichen sclerosis. I would say if it's very severe, you can see ulceration. But if I saw ulceration, I would be doing a biopsy because I would be concerned to rule out obviously something more worrisome like VIN or squamous cell carcinoma. Now there's other conditions that can cause erosion, such as lichen planus. Erosive lichen planus is what it is. And so erosions are like shallower version of an ulcer. It's like almost like the top layer of skin is kind of like off in like usually in a little bit of a circular or a globular pattern. And that tends to affect the vestibule, so that opening of the vagina. And then it can affect inside, in the case of lichen planus, affect inside the vagina, and it can affect the cervix as well. We see these lichen sclerosus and lichen planus are like cousins. So we tend to see that we can see them together. And so anybody that has lichen sclerosus, I'm obviously ruling out and making sure they don't have any other skin conditions like lichen planus. Also, lichen planus can present with an inflammatory vaginal discharge. It tends to be yellow, sticky. We call that desquamative inflammatory vaginitis or DIV. And we see it in menopause sometimes as well. We used to call it atrophic vaginitis. And so these are just some signs that another skin condition may be going on. Another thing that can cause there's many different things that can cause an ulceration picture that are out of the realm of autoimmune skin conditions. There's certain sexually transmitted infections and things like that. So if there's ulceration, I would definitely have that evaluated and see a doctor for that.
Can you talk about where exactly we should be applying the steroids? There's a lot of questions about this.
Yeah. So unfortunately, I can't because everyone's different. And so I would need to know where your lichen sclerosis has been or currently is to give proper instruction on where to apply the medication so it's optimal and it works. So unfortunately, that's going to be different in everybody. And that's why it's important to see someone in the know that can give you proper instructions on exactly where to apply, what to apply, where to apply, how often, and so forth. There's not a one size fits all with this condition, so I can't give one size fits all recommendations, unfortunately.
How do you feel about someone just applying it all over the vulva?
In some people, that may be necessary, but in other people, that actually may cause more harm than good. So it really depends on their clinical picture.
Um, so the next question is it possible to have thickening of the clitoral hood without adhesions?
Like active lichen sclerosis on the clitoral hood without adhesions. Yeah.
Mm-hmm.
It is, and I will say, everybody is different with lichen. I feel that there's some people that have more of the thickening signs and symptoms, and they have hardly any scarring, and then some people have like no itching, none have never had a white patch, have not, they have maybe like the whitening, but they just don't have the thickening symptoms, but they have a ton of scarring. So I've seen all variations of this. Maybe in the future we're going to see actually different phenotypes, but we're just not there yet where we can classify it in that way.
So now we have the non-surgical license for the clitoral adhesions. Does that also work for labial adhesions or?
Yeah, so it's tough because there was a paper that my good friend Rachel did where she referred to this as non-surgical lysis. But like anytime we make a cut in the tissue or a separation using a surgical instrument, then it's pretty much surgical. I think that what she was getting at is that this can be done in the office versus in the operating room, which I totally agree with. I think that there's different levels. What I like to think about is making somebody comfortable for this procedure. So avoiding different, or I'm sorry, offering different options for analgesia, meaning, help with the anxiety component of this, as well as anesthesia, which refers to like actual pain control. So, for example, you can do a lysis with like just putting a topical numbing medication on and do a lysis procedure. You could do that and do a dorsal clitoral nerve block where you're injecting numbing medication to basically like affect the nerves leading to the clitoris temporarily to numb the area to do a procedure, right? You can do that in an exam room. I add an additional layer. I have a machine that provides nitrous and oxygens, like laughing gas, like you would get at the dentist. And so that adds an additional layer of comfort in addition to the other two things that we do. And then in addition to that, I could also, put you under IV sedation, not me, an anesthesiologist that I work with. And then, you could be asleep during the procedure and we could do the procedure. Or even, another layer, which I used to do in DC, is we could take you to an actual operating room and, do a full, under anesthesia. So these are just levels, right? And it depends on what the recommendation for pain control and for anesthesia and analgesia is going to depend upon what needs to be done and how much discomfort that's going to cause, and then how much the patient individually will be able to tolerate. And then some other things go into that, such as costs and time and resources and availability and et cetera, and surgeon preference and everything like that.
Can you give us your thoughts on the tulip procedure?
I don't do the tulip procedure, so I can't comment on the tulip procedure. In addition, the tulip procedure has not been published by a peer-reviewed journal. It has not been submitted for publication. So I honestly, I don't know enough about it to make comment or even replicate it.
What are other well, here's the word non-surgical, again, ways to
It's
help
okay.
with narrowed vaginal opening besides dilation therapy?
Yes, exactly. And it doesn't matter what we call things. Like, I think it's important to have words are important. It's important to name things, but it's also okay to say things and then say, clarify, what are we talking about here? And that's okay. Because a lot of this is, being published, right? Like, a lot of us are publishing these things. And Rachel and Dr. Rubin and I work hand in hand. We've worked hand in hand with different research options. She's like literally my real life friend, as well as we text each other all the time, and a lot of my other colleagues as well. We all work together. We're pretty friendly. So with opening the introitus, with the narrowing, there's different techniques again that we can do, and there's different. I could go into the technicality of it, but I think that's kind of beyond the scope of what we're talking about right now. But there are procedures that are available to restore function, sexual function, or just overall general function for the introitus, to allow for urinary function and things like that. And I think it's just best to go to a practitioner, a surgeon who is experienced in this, who's going to explain everything, who's going to do informed consent, and is going to pick the right procedure for your individual case.
Um, how long after you apply your steroid should you wait to apply a moisturizer, emollient, lube?
Yeah. So if you're rubbing in your steroid completely, it shouldn't matter what you apply afterwards, right? Because it's absorbed. And so I don't think that you necessarily have to wait, but remember that a topical steroid, and I typically recommend an ointment instead of a cream. I didn't go into the logistics of all of that, but in general, creams tend to have alcohol in the base. So if you do have active fissures or broken skin, it can burn. Sometimes when that's someone's first experience, they feel like they have a reaction or it burns. I'm never going to use this again. With an ointment, the other reason that I use ointments is they're lipophilic. Lipo means fat, and philic means love. So they're fat loving. So when and that basement, the bottom layer of that seven layers of skin, the basement membrane is right above our fat layer. It's what attaches our skin to our body. And so it goes skin, fat layer, and then muscle, right? And so if we apply an ointment in the correct manner and it gets down to the basement, it stays in the basement because it's lipophilic for about 3 to 4 days. 3 to 4 days, 3 to 4 days. That's twice a week, right? And so the other thing is that with these bases, like if we're using an ointment base or even a cream base, that's also like it has an emollient quality, right? It's in a base similar to, like Vaseline or, Aquaphor or what have you. And so we don't need to necessarily double dip. What I usually recommend is to use a vulvar emollient on other times, right? Like if we're putting our topical steroid on in the evening, you could do a vulvar emollient in the morning, or using it on the days that you don't use your topical steroid, right? So we have to kind of think about what we're applying and what makes sense as far as what we're trying to achieve with that.
Yeah. So we have about 2 minutes left. I'm going to take one more question and then wrap up here. A lot of people wanted to know, can LS be active and not in remission without symptoms?
Um, I Anything's possible, right? Everyone's an individual with the body, anything's possible. I would say a majority of the time, if LS is active, people usually have some sort of symptoms with that.
And I do want to caveat and say that symptoms are what you can feel, signs are things that you can see. So even in my personal experience, I was in a flare. I didn't have any symptoms, no itching, nothing, no burning, but I did start having resorption. And so, yeah, I had signs, didn't know until I did my vulva check and saw the changes. So technically, yes, it's possible with symptoms, but you might have signs instead of symptoms.
Yeah, and I would say that if lichen sclerosus is active, you always have signs, right? Because active is a clinical diagnosis.
True. Very true. All right. I want to say thank you so much to Dr. Krapf. Thank you to everyone. You guys had amazing questions. I took all of your questions down, and I'm going to see if Dr. Krapf and I can get together later on in the year, and I will do just a Q&A, ask it, and then post it up on our YouTube channel and on the podcast to get you guys answers. Also, please, please, please check out lssupportnetwork.org. We have a lot of the answers to the questions that you guys have put on in the chat on the website. Use the search, keyword searches, it's all there for you. You might have to do just a little bit of digging, but thank you. Thank you, Dr. Krapf. There's so many. Oh, we're getting so many thank yous, so many, so much love in the chat. Thank you guys so much. And spread the word. I know it's really hard to share about your diagnosis, but today is World Lichen Sclerosus Day. So share freely. You don't have to, I share about breast cancer. I've never had breast cancer. I've never even personally known anyone that went through breast cancer. So share freely and let everyone know about LS, because the more people who know about it, the more people get diagnosed, the more people can look for it. And also, I feel you guys on not having any knowledgeable providers in your area. We are working on this. We are launching the Provider Continuous Education Program this year. Knock on wood, we are still looking for more funding on this. So if you haven't donated, please, $5, $10, $20, all of it really, really does help. And we are going to be educating providers, GPs, more gynecologists, dermatologists, OBGYNs, pelvic floor physical therapists, all of that. We are creating courses for, so that you can have someone in your general area that you can go to. And look out, because we've got every month, we've got something for you guys. So keep looking out for our emails. Please keep interacting with us on social media so we can reach more people. And make sure you subscribe to our YouTube channel, so because we have so much more information coming out for you guys, so much more. So thank you so much. Everybody have an amazing rest of your day. This will be available on YouTube. I just have to upload it. Look out for it on our live events playlist. And thank you. Bye, guys.